Hello, everyone. Welcome. We're so glad you are here to join us. I am Marcy Sontag from the Center for Public Health Innovation, and I'm joined by Dr. Mei Baker and Dr. Denise Kay, and I will give more formal introductions of them in just a moment. We are excited to present the second webinar in our webinar series. This one's entitled Cystic Fibrosis Newborn Screening Genetic Resource Centers. This is funded under several different activities through the Cystic Fibrosis Foundation. I want to first give you a brief overview of some CF newborn screening resources. Hopefully many of you have heard about the 2025 CF collaboratives. They are being kicked off right now this month. And in these collaboratives, state public health newborn screening teams and CF centers are joining together to make improvements in CF newborn screening. Meet bi-monthly and talk about various different topics related to CF newborn screening, really to improve what is important to you at your state level. Next, this is a monthly webinar series in which we are going to be talking about lots of different activities related to CF newborn screening. And we will, you can go to our website here through this QR code or through that website down at the bottom, the link, to find out more information and see about the topics of the webinars, view past webinars, and also learn more about our collaboratives. And finally, I'd like to bring your attention to the special issue in IJNS, the International Journal of Neonatal Screening. There's an issue specifically related to cystic fibrosis newborn screening. And the deadline has recently been extended to June 30th of this year, and we would look forward to receiving your publications for that journal, and that link has been put into the chat. So the topic of our webinar series cuts across all of these different topics here, to include starting with the dried blood spot and collection, going into the cystic fibrosis lab testing and IRT and CFTR variant panel sequencing, and then on to communication. Our last webinar was on communication, and today we're going to be focusing primarily on the CF variant panel sequencing. And so many of you are familiar with this slide and this publication of the MMWR in 2004. And this was when the CDC first said newborn screening for CF is justified. And shortly after that, CF was added to the recommended uniform screening panel. I bring this slide back to your attention just to let you know that, just to kind of point out that even in 2004, we had infants with a diverse group of infants represented on this cover. And it's important that we let people know that that diversity was important and recognized then. And yet there's still some challenges in identifying infants with cystic fibrosis of all races and ethnicities. And specifically, I'd like to share Roland's story. Roland is depicted here with his mom and dad just a couple of years ago. And during mom's pregnancy, she had CF carrier screening and it was negative. She had a normal, healthy pregnancy and delivery. And then with her newborn screening test, she did have an elevated IRT. No variants were detected on the panel, and so it was called out as a normal CF newborn screen. However, Roland had consistent challenges in weight gain for his first 6 months of life, and went to see a gastroenterologist, did several different things to try to improve that. But at 6 months, the GI doc suggested a sweat test to put everyone at ease and said, before the Christmas holidays, let's make sure everyone feels better. And it turns out, as you probably expect, that his sweat test was positive. So why was this diagnosis delayed? As Camry, Roland's mom, says, both her carrier screening and Roland's newborn screen only tested for the more common mutations, and neither Roland's mutations were on that mutation panel. His variants are listed here. They were not on the panel in his birth state. His family is of Ecuadorian descent, and so these variants were just not identified. It highlights the issue that infants from minoritized populations are more likely to be missed on many of our CFTR panels, because those panels were typically chosen based on variants seen in white populations. This is true for both carrier screening and neonatal screening. Now, these challenges happen not only at the infant level, but then we can see it at the population level for infants with CF. This is a publication we did led by Dr. Susanna McCulley a couple of years ago, in which we could demonstrate that that diagnosis, the age of diagnosis and the age of first event were both older in Black and Hispanic infants with CF than they were for white non-Hispanic infants. And that then resulted in differences in growth at 12 to 24 months. And the weight for age and height for age Z-score were lower in both the Black and Hispanic infants compared to their white Hispanic counterparts. Now, where I really want to highlight where we see this issue, and this is detection of one variant in fully genotyped people with CF. This is a manuscript from Dr. Megan McGarry a couple of years ago, in which she looked at the various different CFTR variant panels that are being used in newborn screening programs. I highlight here the Luminex 39 just to bring your attention to one, as that's one that's used by a number of CF newborn screening programs around the country. But it's true, you can look at the data, and I really encourage you to look at this manuscript overall. But if you look at this row on the far right side, we see that white non-Hispanic infants, this panel will detect almost 96% of infants for white or not and non-Hispanic with one variant. However, when you look at the other variants, the other groups in African American Black infants, you see less than 80%. Asian infants at 62% and Hispanic infants at 84%. So these panels really run the risk of missing some minoritized infants. Further, as infants who are not necessarily diagnosed early could be because of misconceptions of risk. This was a qualitative study we did a couple of years ago in which we interviewed CF center physicians in newborn screening programs. And one of the CF center physicians said a lot of pediatricians, especially in this certain part of the state, don't believe Hispanic patients can have CF. So it may be if only one mutation is picked up, they may drag their feet about referring the kid because of this misconception. Further, infants who have no variants, CF may really not be on their differential, the diagnostic differential for clinicians. Therefore, a sweat test might not be recommended early on. So because of this, and some other factors related to timeliness and equity in newborn screening, the Cystic Fibrosis Foundation put together an advisory group who worked to look at the equity of CF newborn screening, and recently has published the Cystic Fibrosis Newborn Screening Guidelines. Those came out last month. And I'm not going to go through all of the details of the Cystic Fibrosis Guidelines, but I will point out here that after an elevated IRT, all infants in the United States currently go on for cystic fibrosis, a variant panel, the CFTR variant panel. And as part of these recommendations in this flow diagram, we ask, does the CF panel include all CF causing variants in CFTR2? If not, the recommendation 3 and 4, first, recommendation 3 is to not to use the Delta F508 as their only variant, or to use the ACMG panel. But then recommendation 4 is to consider using the CFTR variant panel, in which you would test for variants in CFTR2 that are known to be CF disease causing. And so it's that recommendation that we're going to really be focusing on today. So some of the questions and challenges that come up when you think about implementing these larger panels in sequencing is, first, there are no commercially available kits for all CFTR2 variants. So if you're going to do this, how would you do this? Why would you make a recommendation and not have a panel to do it? Second, resources in state public health laboratories are limited, and in the current environment, that is even more so. The cost of implementing sequencing on a larger panel is not insignificant. And then the technical capabilities of states to be able to do this can also be a challenge. Finally, the volume of testing in states and individual states might prohibit some of the smaller programs from being able to run sequencing in a timely manner. Further, there are some questions about sequencing. If you're going to do sequencing, what other variants would you include in the sequencing panel? You said, let's include the CFTR2 known disease-causing variants. What about variants of uncertain significance? What about variants of varying clinical consequences? That's kind of a decision for each state to make. And then what do you do with infants with one variant? Do you either call them out as abnormal strain and recommend a sweat test, or do you report them as carriers? And I'll let you know that there is a future webinar that will be dedicated to this topic in July, and we hope you will come back and tune in for that one. But because of this, a group of us approached the Cystic Fibrosis Foundation and said, we think there's a need here for cystic fibrosis genetic resource centers, places where newborn screening programs could send their specimens or get technical assistance for CF genetic testing. So I'm excited to announce the 2 CF newborn screening genetic resource centers, one at the newborn screening laboratory at Wisconsin State Laboratory of Hygiene, and the second, the newborn screening program at the Wadsworth Center, New York State Department of Health. A very brief overview of the services that are offered here. States can provide, or these 2 resource centers can provide comprehensive sequencing of the CFTR coding region and flanking intronic regions. This can include panel-based genotyping, such as the CFTR2 known CF-causing variants. We can, upon request, do the VVCCs, the variants of varying clinical consequence, and potentially do the CFTR gene sequence analysis or reanalysis without the panel restriction. So lots of options there. Many state programs are also interested in potentially doing sequencing in-house. They want to do it on their own, within their own state newborn screening programs, and technical assistance can be offered for that as well. So you can talk to Denise and Mei and get more technical assistance for your program. And some programs are even considering sending specimens to one of the resource centers and then doing that for a short time and then bringing it back in-house once they have those capabilities in-house. So that's a brief overview. And so with that, I'm very excited to be able to introduce the first of our 2 speakers. And this is Dr. Mei Baker. Dr. Baker is a professor at the Department of Pediatrics and director of the Newborn Screening Laboratory at the University of Wisconsin School of Medicine and Public Health. Dr. Baker practiced medicine before being trained in both biochemical and molecular genetics, obtaining a clinical biochemical genetics certification from the American Board of Medical Genetics and Genomics in 2009. She has 20 years of experience in routine newborn screening with specific interest in and a successful track record of applying emerging technologies to implement new screening tests for disorders and improve ongoing screening tests. She has developed and implemented CF newborn screening using next-gen sequencing technology in the Wisconsin newborn screening program since 2016. Dr. Baker served as a member of the Department of Health and Human Services Advisory Committee on Heritable Disorders in Newborns and Children from 2016 to 2021, and currently serves on the National Academy's Committee on Newborn Screening, Current Landscapes and Future Dimensions, which the report just came out today. Dr. Baker, I'll hand it over to you.
Thank you. I saw some construction here. People is okay, right? To hear that? No. Okay, good. So I think you can sense this is a joint presentation. So we all talk different parts. So I choose a certain emphasize, and I hope everybody can see the logical. So first, I really feel the field is changing. And you like or not, next-gen sequencing, we even talk about the newborn screening by whole genome sequencing. So I think I want to use the opportunity, at least we kind of thinking some kind of background in terms of technology, and I hope you find it useful. Then also help you to understand the limitation, what we can do, what are the limitation. So the current newborn screening CF assay by next-gen sequencing in our program we utilize is the Illumina original submitted to the FDA, and the FDA cleaned, called a clearance. But I think we use this as a dry blood spot. So we basically treat it as a LDT and did a fully validation. So the principle is, think about the CFTR gene is a long string with intra exons, and the design is to use a small DNA fragment as the probe to target the area you're interested in, then use a process called the the extension ligation and put them fragment. The tricky is you can tell, and when they have probe, they have a lipid tag. The tag is the next stage will utilize the primer, the sequences. So they use the same primer for everything. So you can imagine and simultaneously happen many sites. And this set actually have 80 to 90 different probe set to define each area. So after that, so you do the primer, the binding, then do the PCR. And interesting, then you have after the primer are leading, then you do extension the primers. You also have an additional tag. That tag is become the binding site for your flu cell. So you just follow this process. So don't get intimidated. You understand the principle. So basically, it's a simple. The concept is simultaneously they have another PCR going and generate we call the library. The library be linked to the flow cell, then you do simultaneous all sequencing. So in this access, I just a certain point I want to make is we did use dry blood spots validated assay, and also people know the disadvantage of use next-gen sequencing is you're not very good at detect the larger deletion duplication and this kind of thing. But I think for this is intentionally, and when you know the boundary where the deleted, location and boundary, and you can software analysis identified. So this assay set you can detect the common larger deletion 2 and 3 exons and 22, 23. This happen most often for the deletion part. And I already said, I said again, is simultaneously detect almost all the variants, not almost, I'm going to correct myself. They can detect all the variants you decide put in your panel. So the panel size can be flexible and what you decide to put in. So this work, this work we have to publish. So this is a work happened to 2014, 2015-ish, and we implemented 2016. So I talk about the next-gen sequencing technology piece, but we all understand that use this larger panel or large genes, you have to have an informatics piece, bioinformatics be accompanying that. So we basically use the CFTR2 as our go-to place reference. And that's this larger database, you can tell I listed here, it's going long history and evolute, getting better and better for multiple parts. One is the number of the patients be including, you can tell. And early on, actually, they started even less than 88 and 600, 64 number, because we started that period. And I mentioned that is around that time, and we started with version 4. But going fast forward, the 2024 and version 15, and they utilize almost 123,000 babies. The more babies you have, the more variety you see, and the more larger the panel you can be. And they are categorized CF cause and variable clinical consequence, and the non-CF and the unknown significance, so that you can tell them more. So the highlight piece I want to say, that's how we practice. We each time follow the update from CPHI, we update our pipeline. So we only including CF cause variants except R117H. And this is the group decision. I don't have time to go too detailed, but so that's common to the limitation. And because we have all the raw data, we always compare with CR2 reported the list, and the certain deeper intron area also more some kind of larger deletion, or I think most of the deletion and a few is the duplication, and this assay have a limitation. So you can tell and what CFTR2 less the CF variance, actually we cannot get 100%. For example, our current, we use a version 14, and they said they can detect, I mean, they're including 719 disease cause variants, but our panel so 689, so not all of them. So this is our current use this. And recently, everybody heard about this FDA LDT rule. For now, it's gone. So give us a liberty to really try to adopt the newer version, and which is have 1085 CF cause variants. But our panel will able to detect 981. And we actually already done fully validation. But we are not, we're going to holding up a little bit until in the fall when our the CF newborn screening committee get it together. We will together make some decision. And Marcy already listed some questions that this will be discussed at our committee, and we will make a decision. And so that's where we are into the utilize the software. I mean the database. So I think come to newborn screening laboratory, I think I can sense that at first things people ask how robust the data, I mean the assay, because you don't want in the position have to repeat this testing so often, and also that's not cheap compared with other assay, right? So we intentionally collected this data, monitor this over the time, and you can tell this is started April 2016 to December 31st, 2024, multiple year together. And when we defined, different categories, success round means the first time you do the done, and at 96%. And we do have some issues, and we try to list here, just give a sense, because they're not assay issues, instrument, tubing issues, whatever. So I have very 100% confidence say assay is robust and very perform very, very good. And this is called each round. And in this long period of time, and I believe we only have one single samples. We said you need to repeat, you need to send another specimen, and we compare with our track assay, and indeed the quality is not there. So I think you can have confidence if you decide to do it yourself. Oh, I'm not a very, oh, sorry. Another things I want to address the turnaround time. Just quick, this is a little bit older data, but I think prove the concept, because this is the period of time we was perform other state, and the state is twice bigger than in terms of sample, the birth rate. So you can sense a little bit shift. If you do more often, of course, the turnaround time is good, but we also take a cost into consideration, because next-gen sequencing, you can do cost-effective only you really can occupy every spot, because the flow cell, you testing one samples costs the same as you test for 46 samples. When I say 46, because we have 2 spots for the controls. So that is I often, people hear me say maybe many times, because we currently do for other states. It's like, it's not I'm doing your favor, actually you do my favor too, because if we can occupy the instrument more often and help us to do turnaround time. So this is one of the things. Another thing is that we knew that, but we consciously made a decision. It's why newborn screening in Wisconsin, I just love working with the group because we all talk together, genetic counselor and CF doctors, and say, I just get fully supported. We said, because of this, we may not do, not may not, we cannot do every day. So if we do, currently, if on our state, we do 3 times for 2 weeks, and even adding on other small set specimen come from other state. And so the decision was made is it's okay if we turn time around 1 week because usually you don't do sweat tests until kids about 2 weeks old. So I think it worked out quite nicely. So I just want people to know that take this into consideration how you do. But also because we have a group decision, we make announcement and set the expectation. They don't expect you give me result in 3 days. And so the report we handle is we have a preliminary report. We have the line say CF testing now because it take more time. So you don't want to scare them and say something wrong. Why I don't have a report? Just simply tell them take more time. Then we have the testing that. Excuse me. We send another report. We also indicated this is a final report, so people don't expect something else. So I think a lot of things, nuance, we can take into consideration. So for what we can offer here is first the consultation. I said that it's not planning, it's what we are doing now. So it's very easy for me to set these slides because we have been doing, I just listed here. So people having the experiences always can contact us. And I do all the different forms. You can call, we can chat, and afterwards I send you the SOP. Or if you want to say, hey, we want our physician hear from you, that's fine. We can just get a virtual meeting. And also, I also do the grand rounds. So we can do all this thing. Of course, we certainly can do device testing because I said it's beneficial for everybody involved. Because we actually develop our own pipeline, and with the mind and with the thought in mind is we can change whatever. Every single time we change it, we do the process, validate them or verify whichever term you use. So not only customer variance panel, but also the analyze the tiers. Yes, because how you choose them, how you, I think the most things I feel I'm very proud of Wisconsin do, not just a laboratory, again, with a physician, with our genetic counselors, is the reanalyze piece. Because all the raw data is there already. So when you have one mutation at this time, we still ask a sweat test. So our group will decide when you have variance, one variance, the sweat test result coming back 30 and beyond, we'll do the reanalyze. And through this exercise, we even find a new mutation. It's to my surprise. I feel like, oh, we know all the Wisconsin. We do so long, we do the, guess what, wrong. Actually, I'm happy to be wrong on this scenario. Just indicated we have so much to learn and indicate the way we're doing things make sense. Another thing I want to use the opportunity to mention that why we use the 30. We all know when you do newborn screening, you have a CIMS situation, right? So our group decided is we're going to use this process. We identify the CIMS ones we want to, because based on the gene typing, the predicted value in terms of CIMS or not, maybe not, always accurate. But with you have this function marker, the reason we choose that is not we want identify CMS, but the evidence indicate can up to 30% of CMS case can change to typical CF. So we think it's obligated. We identify them so clinical can follow them and, knowing the process and identify them when they need a more progressive treatment. And the ones, the CMS less than, unlikely they will have in this category. And if we have this, that's just too many, and the ratio can be more CRMS than CF identified. The ratio can be anywhere from 3 times more or 5 times more. So that's the way the rationale I want to tell you, decided. And I really think that everybody should utilize, reanalyze. Data is there. And if I think we are doing now is if state, I still say if, the state doing that to choose this process is no additional cost because it's there and go back and look, it's not very hard and doesn't take up much time. So we also offer the on-site training. And I think I heard Marcy talk about, hey, you can start with send out, then potentially take it back. That's not just potentially can, it's done. It's done in our laboratory. And we have started doing that, then come multiple times, and they're doing so well by themselves now. So that's, I think is exciting for us. I think it's my last slide, indeed. Thank you for your attention. I'm happy to answer any questions afterwards.
Thank you so much, Mei. That was perfect. And we will come back to the questions that are in the chat afterwards. And now I am excited to introduce Dr. Denise Kay, who is a research scientist who has worked with the New York State Newborn Screening Program at the Wadsworth Center, New York State Department of Health, since 2009. Denise provides oversight for genetic testing and reporting for the newborn screening program. Her work is focused on addressing challenges in newborn screening, including improving testing algorithms, implementing expanded genetic analysis, and piloting and onboarding new conditions. Denise was responsible for onboarding gene sequence analysis for CF in 2017, resulting in 80% reduction in referrals. Denise, I'll hand it to you.
Thanks, Marcy. So I'm going to spend just a couple of minutes talking about the capabilities and offerings from the New York Resource Center. So just a high-level overview of our CF assay. We use a different assay than Wisconsin. This is a custom variant plex next generation CFTR sequencing assay, which is also run on the Illumina platform. It's a lab developed test that's been approved by CLEP, which is our clinical regulatory agency in New York. Our assay permits panel-based genotyping and sequencing as a single assay with a tiered analysis strategy, so similar to Wisconsin. Our analysis pipeline is flexible. We have a customizable second tier panel, and we can basically add or remove variants from the panel by changing a file that specifies which coordinates and nucleotide changes are included in our panel report. And so rather than validating and implementing an entirely new assay at the bench, we just do this analytical validation. Our third tier analysis is also flexible. We sequence the coding region of CFTR. We include intron exon boundaries, a few deeper intronic regions with known pathogenic variants, the intronate poly-TGT region to identify 5T alleles in some cases, and larger exon deletions and duplications across the gene. Our NGS assay uses DNA extracted from a single blood spot punch using a column-based kit. We run CF molecular every day, and we can process up to a full 96 well plate each day. Our typical turnaround time from dried blood spot receipt to return of CF results for babies that are sequenced is about 6 to 8 business days. So let me just show you the New York State algorithm quickly. On the left, you can see the 2-tier IRT CF screening algorithm that we used in New York for 15 years. We referred babies with 1 to 2 panel variants or no variants, but ultra-high IRT for diagnostic sweat testing. And most programs in the United States still use a similar 2-tier IRT DNA algorithm. On the right, you can see the 3-tier IRT DNA sequencing algorithm that we've been using since December 2017. And just as a quick overview, babies with high IRT are reflex to DNA testing. At tier 2, genotypes for a set of specific predefined pathogenic variants known to cause CF are reported. And instead of considering babies with 1 panel variant or ultra-high IRT as screen positive, they now have 3rd-tier results revealed, which includes sequencing analysis with poly-TGT genotyping and deletion duplication analysis across the gene. So only babies with 2 variants of potential clinical relevance are considered screen positive. Babies with a single variant are reported as screen negative carriers with a recommendation for genetic counseling, and babies with no variants after 3rd tier analysis are released as screen negative. And babies in these last 2 categories would have been referred for sweat testing using our previous IRT DNA algorithm. And so the more comprehensive analysis permits referral only for babies who are at the highest risk for CF who have 2 variants. And so the use of this 3-tier algorithm has resulted in reduction of our referral rate by more than 80%. We've increased our positive predictive value by more than 6-fold, and this also allows us to detect rare pathogenic variants that aren't targeted by our tier 2 panel. So just a quick look at some data. To date, we've screened more than 1.5 million babies using this 3-tier algorithm. About 73,000 babies with high IRT have been screened using the tier 2 panel, and about 5,400 babies have had tier 3 analysis performed. We've referred about 830 babies. So in the graph below, the 5,400 babies who are sequenced are stratified by year and into groups of those with 2, 1, or 0 variants after sequencing has been completed. So this is after all analysis. If you look at the bottom in dark purple, we have about 110 screen positive referrals with 2 variants each year. In blue, you can see we now refer about 450 to 500 carriers annually. And in gray, you can see about 170 infants with no variants are released as negative each year. And I'm really just showing this to demonstrate that addition of sequencing can reduce the number of babies that are sent for sweat testing if you refer only when 2 variants of potential clinical significance are detected. So I do want to quickly review just one more set of data because it highlights why we don't just limit our analysis to a predefined panel in New York and why some states might also want to sequence. So this shows the genotypes for 23 CF cases that were identified and confirmed in New York in 2024. And if you look at the top panel, 19 of 23 cases, or 83%, had 2 variants on our large variant panel. But we had 3 babies with 1 panel variant and a 2nd variant detected only by sequencing, and 1 baby who was homozygous for a variant not on our panel. So overall, 17% of our babies with CF in New York State had 1 or 2 rare variants that are not targeted by our large panel. And then further, 2 of the variants, including the homozygous variant, are still not in the latest release of CFTR2. And this is because although these 2 variants are indeed CF causing, they're very rare. And variants that are not in CFTR2 are often from underrepresented and understudied population groups, which was the case here. Both of the patients with pathogenic or likely pathogenic variants that are still not in CFTR2 are not of European ancestry. And so the take-home message here is to consider your population structure when you're establishing your CF algorithm. Just to give a quick overview of what the process would look like using the New York Resource Center, the home lab would screen IRT, identify specimens that need CF molecular, ship the dried blood spot punches to New York with a manifest, and then we'd extract DNA, sequence, and analyze according to the state's pipeline, confirm variants detected, and prepare reports, which would get sent back to the state. And this detailed table outlines what our resource center can offer, and I'm not going to go through the details here. This is something we'd go through when setting up state-specific analysis pipelines. But just as a couple of examples, states can choose whether they want to run just the tier 2 panel or the panel plus sequencing. Whether or not to report the 5T alleles is up to the states, and whether to include deletion duplication analysis. So we can be flexible, and the goal really is to offer states the algorithm that's best suited to their population. If you want to see the current New York State algorithm, you can click the link at the top, or you can navigate through our homepage by clicking on these links here. So you click screened disorders, then you scroll down to CF, and then you click at the bottom here, there's this panel link. And this would bring up a list of variants, an overview of our algorithm, and also a history of changes that we've made to our panel. Are we keeping this slide, Marcy? Did you want me to go through this one?
Yeah, go ahead. Take your
Okay.
time.
So just some quick facts on the Resource Center. So what do you need in order to have New York perform your CF genotyping? Kind of in a nutshell, a contract and 3 blood spots. States don't need to follow the New York State algorithm. The pipeline can be customized to an extent. Could we provide tier 2 genotyping with no, sorry, I'm having trouble seeing this, with no tier 3 analysis? That would be fine. Can we report only pre-specified variant types? For example, do you want to sequence and report out pathogenic or likely pathogenic variants, but you don't want to see the variants of uncertain significance? Sure, we'll provide the data and you can report per your algorithm. We blind the very common benign, likely benign, and non-CF causing variants. The more rare variants that end up being likely benign would be included on a genotyping report, but you could choose whether or not to include them in your final report to patients. We could handle about 260 specimens per week in New York. We would provide genotypes and variant classification. The expected turnaround time would probably be 5 to 7 business days, plus the time to ship, which we'd expect to be overnight. And then the cost is to be determined, which would be largely dependent on the number of samples that you're submitting and the type of analysis. For example, if you want deletion duplication analysis, the cost to validate that is slightly higher. And I think that is now my last slide.
I think it is. So thank you so much, both Dr. Kay and Dr. Baker, for your comments and your very informative presentations. We had a couple questions in the chat. I'm going to go up the line. There's one question about Wisconsin referring variants to sweat while New York does not. I answered it that is correct, that Wisconsin is currently considering a change to not refer infants to sweat test with one variant. But that's still in place, that you are still referring infants to one variant. So when the panel gets bigger, you're considering that change.
Can I add on a couple?
Yeah.
Okay, yeah. So I have to say that I want to share this with you. I think Dr. Rocker's on the call too. I think he can prove I said it truthfully. The whole motivation utilize next-gen sequencing. My dream was when you have one variant, you don't need to do sweat test. But I learned things very quickly. You think you get a 139, you get everything? No, not even close. So the journey has a long, almost 10 years, and but we are not just trying to get it. So we gradually get to today, and so it's why I feel like we are in a very better position now. When you have such comprehensive analysis, and also you open see everything, then you can start saying maybe I can go back to my original thought. So we will see, and still not certain yet until our committee together make decision.
Thank you, May. We also have a question, another one for you, May. You gave assay performance. This is from Joseph Hill in Michigan. You gave assay performance at the entire run level. Do you have an approximate rate of sample failure within successful runs? For example, 1 failed sample per month or 500 samples per 10 runs. If they exist, could these failed samples be the main contributors to greater than 10 per day?
Yes.
Greater than 10-day turnaround time?
Very, very infrequently, because I do the monthly review. So I see everything, and I would say, if it truly is just a sample cost, now that we have other, like one sample run is pass. It's very infrequent. I think another thing, if you have to ask me numbers, I would say on a regular base, I would say more than 5 per month. I wouldn't say that. And I think another thing I want to very specifically say that is, I mentioned that for this many, many years, we only have one single sample didn't go is because when they get repeated, they pass. So that's the kind of scenario. And I'm just giving opportunity to say one more thing, is our set threshold call rate has to be 100%. Otherwise, we repeat it. So you can take all the nuances in that. So we wouldn't feel comfortable if you don't have 100 call rate. Maybe just one mutation you didn't call, then end up the patient has this variance. So we will not absolutely let any sample go if it's not a 100% call rate.
Thank you. There's a question from Erica Wright in Colorado. She said, accessibility of sweat testing is a constraint for some states. How many centers are conducting sweat testing? It looks like Dr. Rock has answered that for Wisconsin, that there are 2 core CF centers in Madison, Milwaukee, and 3 affiliate CF centers in La Crosse, Marshfield, and Green Bay. Denise, do you want to answer for New York?
Sure. So we have 10 centers across New York State.
Okay. And Erica, it's a really good point, especially if you're calling out those carriers. So if you're doing sequencing and calling out infants with one variant, and potentially doing VUSs and BVCCs, and you could have a large number of sweat tests that would need to be done. And I know that's been a problem in some states. So it is an excellent point. And people are more than welcome to also come off of mute if you'd like to ask questions of our presenters.
Chris did have a question that I think Denise answered, but around the V14 for May.
Oh,
V14.
okay. Yeah, I think largely I would agree. And I think the overall, conceptually is there, do the reanalyze of a new evidence, and they do some function study. When they're more, they do. And so ideally, they want to limit this the less and the less. And either you see, of course, or none. That would be ideal, right? So yeah. Can I say, I let people get a question asked and answer first.
Let's see any questions in the chat. Is there anyone who'd like to come off of mute and ask a question?
Can I ask a question?
Of course you can.
All right, super presentation. I've learned quite a bit. Thanks, guys. My question, and probably is directed to Mei, is that I heard that you test for the R117H and presumably the reflex poly T, but not the other variants of varying clinical consequence. And I understand why we would test for R117H. Why have we chosen not to look at those other variants of varying clinical consequence?
I think, I maybe need Dr. Rock help on that too. I think he's one asked me to put it in. Okay, and I think it's because I think R17 is I don't know these words. It's a little bit complicated because you have to take it into the consideration the poly T, poly TG, and there we do see the situation. I think the complicated 5T, and so we do see them have the sweat test, beyond 30, and this one we worry about they change it to typical the CF. And also the R17H, especially compound with another disease cause variance. So that's why. And interesting you ask a question because last CF, the Northern CF Foundation meeting, I did ask Karen from Johns Hopkins, and I think we will perhaps rediscuss this and make some kind of further refined thing, because I personally, what I see a lot of time, I think R17H kind of more headache, I feel, there than the benefit. So, yeah.
Yeah, I think it may be interesting to have more of a discussion about it. Because I
Yeah.
think of all the VVCCs, even though we like more people know R117H, I think it's actually one that's has a lower penetrance than some of the other ones. And that might be something that we could have a whole talk on in one of our further kind of meetings.
Yeah.
I think it's interesting because they're not all the same, right? They're
Yeah,
exactly equal.
I
So
agree. Yeah, because I think the current understanding more like is have 5T and 13TG. I think people think more likely have some, clinical consequence. Yeah.
I'm putting up the contact information, not to stop conversation, but just if you'd like to copy that down, if you'd like to reach out to any of the three of us, please. Our emails are there.
Can I say something? Not
Of course
question?
you can.
Yeah. And Denise, I feel I'm so bad. I didn't do homework as much you did because you have answer question each line. And but I just want adding a couple things. Wisconsin, largely similar, but I think as Denise eloquently described it, and we basically just do the next gen sequencing but a couple things we do ask to dry blood spots. The reason is we need one spot, but consider it if anything happen, we need to repeat or whatever. If you ask another specimen, people have to ship. And so the decision is a mutual decision when we talk to the states, like your choice, but there's pros and cons. But the interesting, everybody chose 2 spots. So this is one of the things I just want to mention to everybody. And another thing is I think I was being asked a price so often. And I can just tell you now, and we charge $100 per testing. And what you can expect is if it costs the change, and we may do some small percentage because if they charge more, we have the economy. I think to me, I'm pretty confident it's a good price because unofficially I heard if you go to a commercial lab and even academic setting, it's 10 to 15 times more. The reason I just want to explain why we can do this, people just, I don't have a magic wand, but what I do have is our instrument, both, we have 2 instruments now, both was purchased on the grant. So when have this happen, we don't counting this to charge it because we got grant. It's, this is one thing. Second thing is we are a nonprofit entity. We don't allow it to, we don't make money.
Mei, you just went on mute.
May, you need to unmute yourself.
I don't know where I get lost, but I think I talk about the grant supported instrument. I think the part of the reason is, secondly is we're a nonprofit entity. And third one, I said that I don't know if people believe or not, because I truly believe if we all grow together, where we are, we just take another up, we all up together. So we need to have the community center. I mean, because think about going forward, it's even not necessary everybody to do on their own. I can tell you today, I don't do cycling. I set out. It's not, I always want to reject, but you have to think about your state, what the need, what to emphasize, what benefit, because it's always can help better screening and for the community care. So sorry,
May I'd love to ask this question, and I'm going to start with Denise and ask this question that Chris Green put in from CDC. As the panels expand, do you recontact individuals as pathogenic variants are added?
We don't go back and test people if we expand the panels. And if there are other pathogenic variants, we would have detected them by sequencing in all likelihood. So we don't need to go back and recontact for those.
Thank you. May, do you want to answer that question?
Sure. We don't, not just the CF, for all the conditions. So our philosophy is it's a screening testing, and when get to the clinic under their care. So I think I don't know how many genetic counselors on the call, and I think they spend a lot of time to keep up the the publication stuff that so because it's part of their practice. If anything new, they need to reassess, and that's part. So I personally, I don't put this on the part of a screening.
Right. Well, thank you so much to everyone for your conversation. Okay, there's more
Yeah,
questions.
did you see,
So-
yeah, Dr. Green added, how about when variants are reclassified from the VUS to PATH?
So in New York, if we had a variant that was reported as a VUS in a patient and was reclassified otherwise in a subsequent patient, we would contact the specialty care center so they could bring that to attention. In all likelihood, what happens is if those are actually pathogenic, you know it the first time because that child will have a positive sweat test. So you actually don't need to do anything. Usually it's that first patient that allows you to reclassify when they have a positive sweat with a VUS. If you do phasing and you do some additional analysis, you can usually reclassify them to likely pathogenic.
So I think for now is because of all the one variants, we do sweat test and find the second one. Usually we know that's an association there. But in the future, what are we going to do? And it's part of it. We need to make a decision. And I still think the general principle is a clinically indicated whatever. Then I think if the information back to the lab, it's good. But I think we've drawn some kind of line there, not to go back.
Yeah, I think this last, Mike Rock may have put a good way to end this is the conversation is ongoing, right? We need to keep having this, thinking about what we're going to call out. So he said, in answer to Dr. Siegel's question, we previously assayed for VVCCs in addition to pathogenic variants. However, this resulted in diagnosing more cases of CRMS and CF SPID than CF annually. And so I think these conversations, there's not a right or wrong answer, and each state's going to need to think about what is it that you would like to do? What's that balance? Are you going to call out all the carriers? Are you going to look for all those VUSs and VVCCs, knowing that you're going to have more CRMS, CF SPID? Like those are all internal questions, and we love to have these conversations. I've talked with a couple of states about what their kind of struggles of how they do this, and there's different clinicians in the state who have different opinions. So you have to kind of think through what's the best fit for you and your philosophy within your state. And so with that, I just want to give another thank you to Denise Kay and Mei Baker for joining us on this call today. This was very informative. I'd like to thank the CF Foundation for helping to support these activities so we can expand CF genetic sequencing as people would like to do so. And we really look forward to hearing from all of you and helping you as you move through these processes. And for those of you who had technical difficulties, we will be sending the recording to people to be able to access the whole webinar as well. So thank you so much. We look forward to talking to you next time.